Good evening and welcome to the Henry Schein Dental Academy webinar series. My name is Adam and I'll be your moderator. We're excited to welcome Becky Horst as our speaker tonight as she will discuss gingivitis and periodontal disease. Before we get started, we have a few reminders for everyone. At any point during the webinar, if you have a question, please type it into the Q&A section of your control panel and we'll reply via email within 2 business days. Henry Schein is not offering CE credit for viewing or attending this presentation, live or on demand, and this webinar is sponsored by Colgate. Becky, thanks for being with us.
Thank you, Adam, for that wonderful introduction. And also thank you to Henry Schein for allowing Colgate Oral Pharmaceuticals to partner with them. So today what we're going to cover is gingivitis and periodontal disease, and how can the body be healthy if the mouth has a disease? So when we talk to our patients about oral health, are they really listening? And are they understanding what we tell them? Or are they leaving the dental office with an important part of information missing? Especially that the mouth is a part of the body, and if there is disease in the mouth, how can the body be healthy? So if this patient saw blood when he brushed his hair, would he be concerned? And also, if this patient saw blood when she washed her hands, would she be concerned? An analogy that I remember from Dr. Ray Williams was the amount of soft tissue in the mouth is similar to the size of the palms of both of your hands put together. So if a patient had an area bleeding red with pus on their body, the size of the area of the soft tissue in the mouth, wouldn't they get that evaluated by the doctor and do what needed to be helped to help it heal and remove that infection? And let's take it one step further. If their palms were bleeding and had an infection, why would they treat one palm 1 week and then wait 2 weeks to treat the other palm? So, with that analogy, are we talking to our patients about the infection that's in their mouth that's going through the rest of their body? Yet, inflammation in the mouth does not seem to stimulate the same concerns as inflammation occurring in other parts of the body. So, periodontal diseases continue to be one of the most common conditions in adults. And in 2012, the CDC and the AAP also warned of significant oral health problem, and half of US adults have periodontitis. I always laugh when I see this graphic because it looks like only half of the United States, the southern half of the United States, have gum disease. But what this does is that shows us that a full mouth periodontal assessment is required to properly diagnose periodontal disease. And if it's not done regularly, patients with perio disease may be missed. So what we're going to cover today is we'll review periodontal diseases and the changes that came out in 2017, 2018. We'll talk about risk factors and how that relates to grading of our patients with periodontal disease, and then some oral hygiene, what we can do professionally in the office, in addition of what those recommendations can be for our patients for home care. So traditionally, oral health was just defined as the absence of disease. That is the old definition. The new definition from the World Dental Federation is that it's much more complex. It didn't take into consideration a person's values, perceptions, and expectations. So this new definition provides a framework that reflects the complexity of oral health. So the World Dental Federation's definition proposes a common understanding of oral health and to clearly position oral health within general health and demonstrate that oral health affects overall health and well-being, and also raise awareness of the different dimensions of oral health and how they shift over time. Empower people by acknowledging how values, perceptions, and expectations impact oral health. So oral health is paramount to overall health of a patient. So what we want is a patient to be able to speak, to be able to touch, to smile, to chew, to smell, swallow, and taste, and express facial expressions without any pain in the oral craniocomplex. So another important factor to consider with adults is what we call the oral systemic link. I think as professionals, many of us know this, but it's defined as the association between periodontal diseases and other systemic conditions. Those most commonly known and reported are diabetes, cardiovascular disease, respiratory disease, also dementia and Alzheimer's. There was the report that came out in July of 2020, and others such as head and neck cancer, arthritis, are other important factors to consider when talking with our patients about oral health and systemic conditions. So the periodontal diseases, So when we talk about gingivitis, that definition really hasn't changed. It's an inflammation of the gingival tissue, and it's a major classification of periodontal disease. And as you will see now, they have two different definitions for gingivitis. And gingivitis can be reversible. Also, if it's left untreated, gingivitis may progress to periodontitis, destroying the two supporting structures. So when we compare gingivitis and periodontitis, many of us know this. We talk about biofilm. It still continues to be the major contributor. And the key is gingivitis is reversible, periodontitis is irreversible, but we can maintain those patients or arrest the disease. So again, periodontal diseases, serious chronic infections, involves destruction of two supporting structures of the gingiva, the periodontal ligament, as well as the alveolar bone. So periodontal disease is by the accumulation of bacteria. The host immunologic reaction determines the susceptibility to the disease, and the host responds, essentially protective, which can result in tissue damage, and it influences the severity and rate of progression. And chronic and aggressive were terms that were used in the 1990 classification. Those, as we go through the new classifications, that chronic and aggressive periodontal disease classification is now gone. So biofilm continues to still be the problem with many of our oral conditions. It's a very sticky substance, and it has its own ecosystem, and it's very difficult to remove. So the biofilm has to be mechanically removed. And again, to review the development and maturation of dental plaque. So it attaches from the saliva, early colonization, and then we have where it proliferates and it continues to seed and disperse, meaning it's building more colonies. So how are we going to mechanically remove this biofilm? So what are we treating? When we talk about what we're treating in the dental office, we assess for risk factors for many different diseases or conditions. So periodontal disease, caries, oral cancer, dentin hypersensitivity, erosion, halitosis, and even dry mouth. And we do this we diagnose them through different by using the tools of clinical exams, our digital x-rays, dental and medical history, and also different digital tools. The most common risk assessments that we use in dentistry are the periodontal disease risk assessment, caries, and oral cancer risk assessments. So when we talk about the classifications, in 2017, there was a workshop that was put together by the AAP and the EFP, the European Federation of Periodontology. And so what they did is they wanted to refine the classifications, and they used the current evidence and also lower level evidence, and then expert opinion intended to improve us as clinicians in understanding the appreciation of disease, and then also incorporate the presence and control of risk factors in the diagnosis, and highlight the individualized complex nature of a patient to their response of their treatment. And so there is you're able to go ahead and you can download. I will have the other website, so you can go ahead and download the different materials that's available. So what's different from 1999? So what was added? So we have classification now for gingival health, the staging and grading, and then also classification for implants, gingival phenotype and mucogingival classification. So what was eliminated was the aggressive and chronic classifications. So in the previous classification system, the periodontitis was divided into 4 categories: chronic, aggressive, both localized and generalized forms, necrotizing, and manifestation of systemic disease. So now the periodontitis is now grouped into 3 categories. So it's grouped into necrotizing, periodontitis as a manifestation of systemic disease, and periodontitis. And then it also added the implants. So implant dentistry become a major component of patient treatment planning since 1999, the last release. So, and just like the tissues that support the natural teeth, the bone and soft tissues surrounding dental implants are susceptible to inflammation complications without proper care and management. So let's go ahead and take a look at the new conditions. I know this is a lot of information here, but I'll try to make it fun. But so now you can see that they have periodontal health and gingival diseases. So periodontal health is now defined by the absence of clinical detectable inflammation. And clinical gingival health can be found on a periodontium that is intact with without clinical attachment loss or bone loss. And on a reduced periodontium in either a patient without periodontitis or in a patient who has a history of periodontitis who is clinically stable. So that we now have our terms for what is periodontal and gingival health. Then we have gingivitis that is caused by biofilm. So biofilm alone, systemic or local risk factors, and also drug-induced influenced gingival enlargement. And then in addition, with gingivitis, it's gingivitis that is not caused by dental biofilm. And this is where if we remove that biofilm, we're still presenting with gingivitis, and the patient's medical history should be reviewed to see what the possible oral systemic conditions are. So some of those possible causes could be like different genetic and developmental disorders, specific infections, inflammatory, and immune conditions and different reactive processes, and also metabolic diseases and different traumatic lesions. So that is a grouping of our periodontal health and gingival diseases. Then we talk about periodontitis. It is now grouped into three different terms. So we have periodontitis, and then it is also, we have necrotizing periodontal diseases that present clinically basically with the papilla necrosis, bleeding, and pain. And that's associated with the host immune response and impairment. So the diagnosis is based on a history, whether there is a systemic condition that is altering the patient's immune response. And then periodontitis as a manifestation of systemic disease. This category was developed to account for the systemic disease conditions that affect the periodontium. And these are sort of rare conditions that result in periodontitis, and they would be in this group of periodontitis. And then we also have other conditions. So this would be other. So that's number 3. So these would be systemic conditions, systemic diseases associated with loss of periodontal supporting tissues, as the neoplastic diseases, endodontic and periodontal lesions, where the bacteria is transferred between the pulp and the periodontal structures. Also the mucogingival conditions. So this is going to relate. They've also have given this a new term, and there's a whole new classification system for recession. And so they're looking at the gingival recession based on the interproximal loss of clinical attachment. And it also includes the assessment of the exposed root and the CEJ. So there is new classification system for recession. And so when we talk about periodontitis, we'll come back to this because we're going to talk about this classifications and then how we classify and we stage it. And we also talk about the progression. But let's go ahead and talk about the 4th classification, and that's our peri-implant diseases. So peri-implant health, right? There's no BOP, no bleeding upon probing, no inflammation. Peri-implant mucositis is described as there's biofilm present, there's BOP and inflammation on the soft tissue. And peri-implantitis is biofilm is present, we have BOP, inflammation, and then we're also seeing radiographic bone loss around that implant. And so when it refers to the peri-implant soft and hard tissue deficiencies, what that means is that after the tooth has been lost, it leads to a diminished alveolar ridge or process, and additional treatment may be indicated prior to implant placement. So now that we went through the new classifications of health, periodontitis, and other conditions and implants, let's go ahead and move on to the staging and classification. So this new classification system is taken from medical models. So think of a cancer diagnosis. So such as a type of, you're diagnosed with the type of cancer and what stage you're on. And so then the doctors can develop a well-rounded strategy and treatment based on that specific patient needs. So staging in dentistry is based upon the severity of the disease and the complexity of the disease management. So there are 4 stages with periodontal disease. One through 4. One is the least, or is the mild disease, and then level 4, stage 4, is the most severe disease. So stage 1 would be patients that have a probing depth of 4 millimeters. They may have some clinical attachment loss of 1 to 2 millimeters, and horizontal bone loss. So most likely these patients will require non-surgical treatment. We're not expecting any tooth loss post-treatment, and there's a pretty good prognosis of this patient being able to go into maintenance. With stage 2 periodontitis, this is considered like the moderate stage. Patients will have a probing depth of about 5 millimeters. The clinical attachment loss, 3 to 4 millimeters, and horizontal bone loss. And these patients may require some non-surgical and surgical treatments. And it's still, we're not expecting any tooth loss. And so this case would have a good prognosis, again, of going into maintenance. Stage 3, which is severe disease, patients have probing depths of 6 millimeters, clinical attachment loss of 5 millimeters, and they may have vertical bone loss and furcation involvement. These patients will require surgical procedures, as well as possible regenerative treatments. And there is potential about 0 to 4 teeth. And so this patient may require multi-specialty treatment, but overall the case may have a fair prognosis of being able to go into maintenance. And then stage 4 is very severe disease. These patients will have probing depths of greater than 6 millimeters and may have vertical bone loss and furcation involvement of class 2 or 3. Fewer than 20 teeth may be present, and there is a potential loss of 5 or more teeth. So advanced surgical treatment or regenerative therapy may be required, including surgical treatment or regenerative therapy may be required, including augmentation to treat to facilitate implant therapy. So this patient will, again, require many multi-specialty treatment options, and the overall case has a questionable prognosis of going into maintenance. So those are the 4 stages. So what you do is you go ahead and stage the patient. And then from there, you grade them. So grading is like risk. So it's the risk of progression. And the characteristics that go with risk would be grade A. So you could have a level moderate periodontitis patient, but they may be a low risk. And what they're looking at is that there's no bone loss or clinical attachment loss over the last 5 years. The patient doesn't smoke. So this is where they're taking those risk factors of smoking and acquired disease, such as diabetes. So they're looking that there's no smoking, no diabetes, and there's heavy biofilm, but there's no destruction. So that would be a low risk. Then grade of B would be a moderate risk of progression, and they have less than 2 millimeters of bone loss over the last 5 years. In addition, they may be a smoker of smoking like less than a pack a day. And also you can look at their HbA1c, it's less than 7%. And then also their biofilm concentration. So that would be a moderate risk of progression. And then the C is the high risk of progression. So these patients they have more than 2 millimeters of bone loss and clinical attachment loss over the last 5 years. They smoke more than a pack a day. And also we're looking at their or HbA1c if it's greater than 7%. So that can classify them into the grade C for rapid risk or high risk of progression. And then what we need to document is also the extent and distribution. So that's defined as localized, generalized, molar, and incisor. So localized would be bone loss is less than 30% of the teeth in the mouth. And then it's generalized, meaning it's more than 30% of the teeth. And then if it is molar or incisor, meaning if it's found around generally the first molar and the anterior teeth. So we go through, we stage it, then we give the patient the grade of their risk of progression and then the extent. So this is something that you're able to go ahead and download. You can go to www.perio.org/2017 WWDC. So you can print these off and place and laminate them. It just helps you staging, especially if you're not used to this new system of staging your patients. And it walks you through how to stage. And I know I went through the different probing deaths, but it also breaks that down for you. And then at the bottom, you're able to see here where it talks about the extent and distribution, generalized or localized, and then also your grade modifier. So it talks about their diagnosis and, if they have the acquired disease of diabetes, and if their risk factors are also smoking. So you're able to go ahead and download these. I like to slide it in, either laminated and have it available chair side, so you can go ahead and review that. There's also in that website, you're able to look at some frequently asked questions. And I would recommend taking a look at those frequently asked questions, because it talks a little bit about EOB with insurances and third-party reimbursement. It doesn't sound like it's there yet with this new grading system, but as time goes on, it sounds like those third-party reimbursements may change because of the documentation of the new periodontitis grading and classification system. So let's go ahead and talk about risk factors and the periodontal balance. What we do know is that, determining the risk allows identification of the best and preventive measures and overall management. So studies have reported that the risk factors in and of themselves were not etiologic, but rather modified or exaggerated with the risk factors. And so then these processes can be put into motion by the bacteria, and these risk factors they've evolved since the 80s and 90s. And so it includes different genetic elements, also environmental, such as faulty dentistry, overhanging and subgingival margins, and then different behaviors, again, as smoking, acquired disorders such as diabetes. And the concept of modifying risk factors as a part of the management of periodontal disease is well established. So risk factor modification, so reducing those risk factors. What we will talk about is reduction of risk factors as well as reduction of bacterial challenge. So on the professional side, the professional reduction of bacterial bioburden is mechanical therapy. So those non-surgical procedures, the scaling and root debridement, using our ultrasonics, piezo or magnetostrictive. Also, to go and check out the new subgingival powders that are now FDA approved in the United States, such as the erythritol and glycine, in helping to remove that bioburden. Also, you can use antiseptic rinses and irrigation, and the surgical reduction of pockets, and then topical antimicrobials. So chlorhexidine can be placed onto a medium, and then it's placed into the pocket, and that chlorhexidine is released over 7 to 10 days. Also, another gel can be placed into the pocket, and it's basically doxycycline over 7 days. And then Arrestin. Arrestin can be also injected in about up to a 19-day release of minocycline. In addition, systemic antibiotic therapy can be used. It's an easy administration of drugs, and it gives it to multiple periodontal sites. But patient compliance needs to be considered because the inability to achieve the proper concentrations at the site of infection and also adverse drug reactions. And there is also fear of the development of antibiotic resistance can be an issue. But the common antibiotic therapies for treatment of periodontitis include clindamycin, doxycycline, or minocycline. Also, azithromycin and other antibiotics can be prescribed to those patients. And then for those adult patients with acute periodontal abscesses, amoxicillin can be used as an adjunct to incision and drainage. So at home, reduction of bacterial burden, so oral hygiene, dependent on the patient's knowledge, technique, and the abilities and their patient's compliance. And the antibacterial containing dentifrices, which we'll review, and also talk about mouth rinses as adjuncts and aids of plaque control. So this is from the ADA, and it's talking about home care oral recommendations. So no two people are the same. So we're talking about individualized treatment options for those patients. And so, advise all patients, right? Brush teeth twice a day with fluoride toothpaste, even though we know they only brush for 46 seconds. Clean between the teeth. Eat a healthy diet, limit sugary snacks and beverages, see a dentist regularly. These are all things that we're telling our patients. Also, for patients with increased risk of gum disease, the ADA recommends a mouth rinse and toothpaste that has antimicrobial activity. And for patients with increased risk of caries, even though we're talking about perio today, consider a fluoridated mouth rinse. And for patients who struggle to clean between their teeth, consider different interdental cleaning tools. And also for patients seeking or needing improved plaque control and removal, consider a power brush. And then our lifestyle considerations, the tobacco cessation, recommend that patients avoid oral piercings, recommend patients drink fluoridated water. This is also where we can go into our nutritional counseling with those patients that have diabetes. So when we talk about brushing, right? So to look at manual versus power. As a clinician, power is better, but 86% of the population use a manual toothbrush. And 62% of these manual toothbrush users are not interested in using a power toothbrush. So there's a way that we can overcome that and introduce some of the new technology that's available out there, and talking about connected health, where we're getting actual feedback from that toothbrush in real time. So that is a picture of the hum brush, but this is a true connected app, meaning the patient will have this app available on their phone, and in real life they can brush, and it will tell them if they're brushing too hard, too fast, and also if they've missed an area. It also has a little bit of fun to engage you. It has daily quizzes, but it's giving you real-time feedback of your brushing habits. And if you're not have the app open when you're brushing, you can go back and open up the app, and it will tell you your coverage, your percent of coverage. So imagine me as a hygienist brushing with the app, and then I was like, okay, let's test this baby out. So go ahead and brush blind in a sense, and then go ahead and open up the app. And I only had about 93% coverage. There were some areas that I missed. But the one thing I discovered on my own is that I actually brushed longer than 2 minutes because I was trying to see how well I would do, but I did miss some areas. So this would be nice for, to make that recommendation even for parents for those children or adolescents that may not do a good job at brushing. The parent can instruct that adolescent to go ahead and brush, and then open up the app and send them back if they need to rebrush. But this is also good for our patients that are poor brushers, to give them real-time feedback in their abilities. This was a paper that was presented at the IADR with Colgate and several dental universities. And what they looked at was they took the same power brush and gave it to the participants over a 6-month period or 6-week period. And half of the participants brushed with the power brush only, and the other half brushed with the actual connected app. And so what we can see is that the connected toothbrush, we had much better gum line reduction and interproximal plaque removal with the connected app actually working. So by taking the idea of gamification, I mean, who doesn't love games on their phones? But taking the idea of a gamification with that connected health and implementing it into our oral hygiene care at home. In addition, with interdental cleaning, the recommendation of floss, different interdental aids, different type of interdental brushes, and then also a water flosser. I think that's sort of funny, but if they're that picture is funny, but there's many different types of interproximal water flossers that are available to make that recommendation. So whatever you feel will best suit your patient's needs for interdental cleaning. So toothpaste does matter. So we've talked about manual toothbrushes and power brushes. And so toothpaste does matter. A lot of times I will talk to different clinicians at my universities, and they sort of roll their eyes. As long as they're using a toothpaste, it's okay. But different formulations and ingredients equal different toothpaste. So all the different manufacturers, we have all of our different recipes. But as a clinician, what we want to do is look at the ingredients that are in that toothpaste and what ingredients are there to help that patient with that specific condition. So some of the common active ingredients that you'll see in toothpaste, hydrogen peroxide for bleaching. It comes in basically 1 to 3% in toothpaste. Potassium nitrate is in toothpaste as an active ingredient, and that's for dentin hypersensitivity, and that will depolarize the nerve. Also, arginine is in toothpaste, and it will block the dentin tubules, so that also helps with sensitivity. And then we have fluoride in toothpaste. So remember I said they were like, oh, as long as they're using a fluoride toothpaste, I don't care. Well, that's good for caries. But when we talk about MFP, sodium monofluorophosphate, and we can also see sodium fluoride, those are great for caries prevention. Stannous fluoride is also, but stannous fluoride also has the additional benefit of being bacterial. So what the stannous will do is the stannous will go ahead and coat the bacteria, and it starves them, decreasing their ability to release acids and toxins. And it also creates a mineral shield on the hard and soft tissue, providing additional antibacterial benefits. So stannous fluoride has been around for a long time. It was a tried and true toothpaste, multifunctional. It's anti-caries, anti-gingivitis, and also stannous will occlude the tubules over time. So stannous has always been difficult to formulate. Toothpaste manufacturers have struggled for this with over 60 years. So some of the complaints is that the toothpaste can feel runny. Sometimes it can also be really gritty. And sometimes because of the way it's stabilized is that also patients may complain of seeing staining on their teeth. So why is it so difficult to formulate stannous? So since the challenge has been is that the stannous ions, they easily oxidize in the presence of water and air, which renders the stannous ions inactive. So water is a key ingredient that is in toothpaste. So it oxidizes. So think of it, we leave a piece of metal out in the yard. When it rains, what happens? It rusts or oxidizes. So that's what happens with the stannous in toothpaste and making it inactive, and also causing it to that's where you would see on the pellicle where you may see staining with stannous products. So a new formula of stannous toothpaste is Colgate Total. So they take stannous toothpaste and they've added zinc phosphate. And so the zinc phosphate, what it does is it stabilizes the stannous in preventing it from oxidizing. So you don't have those traditional issues of staining. Then let's think about our teeth. Our teeth take up about 20% of the oral cavity, and the remaining 80% is soft tissue. So the saliva can transport that plaque and bacteria from reservoirs and then onto the cheek, tongue, and other soft tissues. So what the stannous will do is adhere to those soft tissues and create that mineral shield to help kill the bacteria. So Colgate Total, it is stannous fluoride and zinc phosphate, antibacterial, reduction in biofilm, reduction in gingivitis, cavities, whitening, reduction in the amount of calculus, enamel, and fresh breath. That was the traditional benefits that the old Colgate Total before the formula was changed to stannous fluoride. And so now, because it's a stannous fluoride toothpaste, it also provides sensitivity relief, enhanced enamel strength, and odor neutralization. I like this toothpaste. If you've ever had one of those stinky patients, have your patient pre-brush with this. First of all, it'll remove some of that biofilm before you have to do any type of scaling or deplaquing of that patient, but it instantly neutralizes their bad breath. Another product for our periodontal patients is the Gel-Kam. Gel-Kam is no longer a prescription. It's available over the counter or available from the pharmacist. And you could also dispense this in your office. So this would be for those patients that would have sensitivity and after perio procedures. The patients would need to brush with their regular dentifrice or their Colgate Total, and then they would go ahead and brush the Gel-Kam Gel on and expectorate. So there are different variations of mouth rinses. Their mouth rinses are divided into cosmetic and therapeutic products. Cosmetic mouthwash, it masks the bad breath temporarily by a flavor composition that gives you a fresh, invigorating feeling. And then the therapeutic mouthwashes, by contrast, have active ingredients to help mechanical control and maintain oral health. So with those therapeutic mouth rinses, we have hydrogen peroxide, the essential oil rinses, fluoride rinses, chlorhexidine, and then also the CPC rinses. So when we talk about hydrogen peroxide, it is a 1.5% hydrogen peroxide, and it is stabilized, and it is antiseptic rinse to help lower oral bioburden, and it cleanses and promotes healing of minor oral wounds. I always tell all of my friends, everybody needs to have this in their medicine cabinet. I cut the roof of my mouth on a, pizza burn and go ahead and rinse with this, and it soothes that sore, and it just feels so much better the next day. So it is also, Peroxyl is also alcohol free. You can use this as a pre-procedural rinse to reduce the bioburden that may be generated during the procedure with aerosols, and also use it as a post-procedural rinse. So after you've done a scaling and root planing procedure, also possibly after if there was an extraction, have the patient rinse with that post-procedurally just to soothe and help begin healing that tissue. You can also get this and dispense it to your patient in sachets, small sachets, to send with your patient home to get them through those first few days of healing. The CPC rinses, they primarily act by the CPC, what it is, it's a positive charge in the CPC. And what it does is it latches onto that bacterial cell, which is a negative charge. And so what it does by it penetrating that bacterial cell membrane, it causes leakage of cell components and disruption of the bacterial metabolism and the inhibition of the cell and finally cell death. So this is a picture of the Colgate Total Mouth Rinse, 12 hours of antibacterial protection even after eating and drinking, and it kills 99% of bacteria on contact. So a CPC rinse for recommendation. And then our tried and true, our 0.12% of chlorhexidine gluconate, it's an antibacterial, antiseptic. It's effective against the gram-negative and gram-positive bacteria. And again, it is prescription only. You are able to dispense it into your office, and it's intended for short-term use, post-surgical to prevent infection. And it's the gold standard of antimicrobial therapy for the treatment of gingivitis. So the one thing, the side effect is the staining, supragingival calculus, and it can sometimes have a taste disturbance and alteration for the patients. This is a picture of Colgate's chlorhexidine Periodontal, and the formula has been changed and it's now alcohol-free. So Periodontal is now alcohol-free. So how do we engage our patients in their oral health? So we've gone through and we've talked to our patients, we've classified what stage of periodontitis they have, and then we've graded them, and we've talked about their extent and distribution. So there is a tool to help send our patient home with the message that we've delivered to them, to make our patients agreement to accept their conditions that they have and accept your recommendations of their oral care routine. And it's called the Gum Health Physical. So you're able to, this is a free interactive program that you can log onto at your chair side. You can log into your mobile devices also, but you go into Colgate Professional. You can enter your credentials, and if you have your username, it gives you a lot more robust help to go ahead and log in. So if you don't already have a Colgate Professional login, you can go ahead and create one. It's pretty easy to do. So when you go to colgateprofessional.com to utilize the site, by enrolling, it entitles you to valuable professional and patient education. And also you can customize it with your practice name. And if you don't opt in, you may select the X in the upper right corner of the login screen, and you can still utilize the Gum Health Physical tool without logging in. So once you are in, this is what the landing page will look like. So you have the basic dentition there, and it's just meant to give our patients a quick look of the areas they need to focus on. So you can go ahead and click on the tooth, and when you click on the tooth, what will happen is it will turn red. And if you click on it twice, it will X the tooth out that tooth is missing. So that would be a dental charting that's going to show your patients where they need to improve. Then the patient education tab of the Gum Health Physical. This is my favorite part. How many times have we tried to show a patient in the mirror what a 5mm pocket looks like? The patients can't see, they're laying back, they may just nod their head and agree. But what this does is it puts it into a digital tool, and you're able to say, Mr. Smith, when we did your periodontal probing, you heard that I called out you heard me say 5 several times. What we know is if we don't remove that bioburden and that bacteria that's in that pocket that we can't reach during a normal cleaning, is that infection can progress to a 6mm pocket and on, or however you would like to frame it. But what this will do is this interactive tool, when you pull down on it, it will allow you to show the depth of the pocket. So you can see here where it goes all the way to a 12mm. So you're able to show the patient full size, where the patient is able to understand if it's left untreated, then that patient can have that. What we do know is that it will progress. There are also different videos to click on. So quick little vignettes on brushing teeth, on flossing, and just shows the destruction of periodontal disease for patient education. Also, you can customize a report. So you can go through the treatment that was done today, the patient's risk factors, diabetes, smoking, plaque control, their next recommended visit, the patient's home care instructions, the use of a power brush, what toothpaste should that patient be using for their condition. Also, what type of mouthwash, and what additional interdental tools they should be using. And then you can also personalize the instructions. Maybe not to have sugary drinks throughout the day. If you're going to have your soda that you like, have it at lunchtime or at mealtime, or whatever different personalized instructions that are not covered. And then from here, what you can do is print this off if you have the capability to print from your operatory, or you can go ahead and download it and you can email it or text it to the patient if you have that capability with your device that you're using. And so the patient would receive a customized report. They would see the treatment that was done, the risk factors that they have, their next visit, and then the home care recommendations that you've made for those patients and their personalized instructions. So many times our patients are heading out the door. We may be scribbling down of what we're recommending for the patients. This way, they have their condition that you've discussed with them about, and then also those treatment recommendations that you have for your patient and their home care instructions. So by going through and doing our risk assessments, what we're able to do is we know with our risk assessments and what we know with disease progression that we can be predictive. We can also be preventative with our patients and then personalize those instructions with our patients. And then also participatory with our patients. So by using something like the Gum Health Physical to personalize those instructions. And then the idea is that our patients will be able to participate in their recommended home care. So patient education is important. So our patients are more aware than ever, but however, we need more motivation and information for our patients. And the patients are dependent upon the healthcare professionals to educate and motivate and provide the resources. And so what's next? So with the information that we covered today, what are you going to do differently in your practice tomorrow in terms of periodontal treatment and recommendations for your patients? And again, I would like to thank Henry Schein and thank you and hope you have a wonderful day.
Thank you, Becky, for your time this evening. And thanks to Colgate for sponsoring this webinar. If anyone has additional questions on this topic, please feel free to email us at webinars@henryschein.com. Additionally, if anyone's interested in attending future Henry Schein webinars, visit henryscheindental.com/webinars for our upcoming schedule. As a thank you for attending, everyone will receive this recording of the webinar via email sometime in the next week. Thanks for joining us, and we hope to see you back here on future webinars. Have a great night.